Hello, my name is Ghazala Imran. I'm a fourth year anesthesiology resident, and my presentation for the QueST submission is: Does airway view optimization using video assisted laryngoscopy improve intubation efficacy? So, just to start off, the advent of video assisted laryngoscopy has really expanded the scope of which providers can manipulate and secure an airway in a patient. This expands not just to anesthesiology, but also now in the ER as well as in the ICU. So, there has been evidence to show that using this technique over just a regular laryngoscopy can improve the success of intubation, particularly in patients that are known to be a possible difficult airway. However, there really isn't any literature showing the different processes of getting a view and how that affects the success rate of getting an intubation with these new video assisted techniques. So, this pilot study is the first of its kind, and we aimed to try and identify different ways that optimizing the view on the video scope would result in either better or worse or no change in the success rate of the intubations. What we predicted would happen is that optimizing the view with the particular airway structures that we will go over would in fact make the intubations easier and reduce the number of attempts made. So the methods that we used, this was a completely categorical data study used by different observers that would go into the operating room where a video assisted laryngoscope was being used. So essentially, we would be able to watch the screen and see what landmarks were available to the provider and how many attempts were made and how long it took for the patient to be intubated based on what was seen on the screen. So this was purely observational. And as of right now, we were able to get close to 100 now, but for the sake of this presentation, 79 separate intubations. And we observed a wide scope of providers, everything from anesthesiology attendings, anesthesiology residents, CRNAs, and student CRNAs. So we tried to compare two different categories of views that we would consider optimized and views that were non-optimized. And so what we were able to find looking at the figures, so figure one is going to show what we would consider from an anesthesiology perspective an optimized view, meaning that you have all these significant airway structures in the view in the center of the screen. And with the corresponding arrows, you can see at the top, the epiglottis is clearly visible, as well as the arytenoids, the arioepiglottic folds, as well as the vocal cords. And not just that they're visible, but they're aligned with the center of the screen. They're not off to the side. And this was the view that we would consider an optimized view. So based on what we looked at, it did show that patients that did not get an optimized view with the video laryngoscope actually required more intubation attempts. And this was a statistically significant value of negative 0.05 for the p-value. We also looked at the duration and the time it took to successfully secure the airway, and that also was a statistically significant value. Looking as well at the duration when just the arytenoids were visible, so what we would call a sub-optimized view, that also showed that the duration or the attempts made to intubate the patient were significantly changed. So if you were not able to visualize the arytenoids, which are the two structures just below the cords, it took you significantly longer as well as more attempts to successfully secure the patient's airway. So basically, what we can conclude from this is that when we compared the optimized views to the non-optimized views, there was about a 20% increase in intubation attempts, as well as a 50% increase in the intubation duration when there was a non-optimized view. So what we've gathered so far is that having these structures, especially the arytenoids, in the view before the endotracheal tube is passed into the mouth and attempted to intubate, that actually improves the duration as well as the attempts made and prevents any excess instrumentation of the airway, which can cause bleeding, swelling, and potentially a disastrous situation for all of the providers. So the plan is to continue this study, and any intubation that is requiring a laryngoscope in the operating room that we observe and try to see if the views continue to improve not just the attempts, but the duration for these intubations. This is the end of my presentation. Thank you for listening.